day, students. Welcome to the last in the series of podcasts for cardiac nursing. Today we'll talk about cardiac pharmacology. It's very important with a vast array of illnesses in cardiac nursing today, and so many medications to treat these illnesses, such as hypertension, myocardial infarction, congestive heart failure, etc., that you learn the classifications of the drugs. It's not possible, nor is it advisable, to memorize these drugs. Because tomorrow, for instance, there'll be a brand new beta blocker out on the market, and you'll need to be able to figure out how that beta blocker is different than the one that you're currently using. And why is it better? What are the advantages? What are the disadvantages? In order to be able to adapt quickly, as you need to do in nursing today, you need to know your classifications. So we'll focus in on the classifications, and we'll go over some of the prototypes of the various classifications, and I would expect you to know them. So let's talk about the classifications now. Here are the 5 major classifications. There are beta blockers. Some are selective in that they only block beta 1 receptors in the heart. Then there are some that are beta 2 selective beta 2 receptor blockers as well. Not really helpful for us because beta 2 receptors are where? They're in the lungs. So we need to talk about those. Then there's the calcium channel blockers. And there's 2 types of those. They have fancy names. There's dihydropyridines and then the non-dihydropyridines. So basically understand that the dihydropyridines have to do largely with blood pressure regulation, and the non-hydropyridines act really just like beta blockers with just rate reduction. So very different, although they're calcium channel blockers. And if you remember back to your days of physiology, you'll understand that calcium was intricately involved with muscular contraction. And so therefore, calcium is very important pharmacologically in how we manipulate the smooth muscle that lines some of the arteries and veins to allow for promotion of vasodilation or relaxation of those muscles to promote vasodilation and therefore lowering of blood pressure. So the next classification of drugs is angiotensin converting enzyme inhibitors, otherwise known as ACE inhibitors, and they are intricately involved with angiotensin, so angiotensin being a potent vasoconstrictor in the body, and these drugs block the production of angiotensin. And so we'll look at that classification of drugs and how it promotes for vasodilation. And digoxin and how it relates to management of congestive heart failure. And lastly, nitroglycerin as a prototype for vasodilators. Okay, here are some of the drugs, some of the beta blockers. Beta blockers can typically be recognizable by their suffix LOL, and I like to refer to that as lots of love. So most of your beta blockers, as you'll come to see, such as propranolol, atenolol, metoprolol, timolol, all end in LOL, lots of love. So they act by blocking certain receptors for catecholamines or norepinephrine and epinephrine in the sympathetic nervous system. And as you'll remember back in the podcast number 2, we talked about the autonomic nervous system and the sympathetic nervous system more specifically, and the effects of epinephrine and norepinephrine on heart rate. So of course with the sympathetic nervous system, the heart rate increases. So blockade of sympathetic nervous system or norepinephrine or epinephrine causes a decrease in heart rate. So beta blockers cause a decrease in heart rate. Now that's in beta 1 blockade. Unfortunately, if these drugs are not specific, they can also cause beta 2 blockade. So all of the other things that we talked about when you saw the bear can also occur if you do not have just beta 1 blockade. So beta 2 blockade can also cause increased airway resistance or bronchoconstriction. They can also cause a suppression of reflex tachycardia. In essence, when a patient has orthostatic hypotension, such as in dehydration, you will not see that compensatory increase in their heart rate when the systolic blood pressure drops below or drops by 20 points. You also have a reduction in renin formation and therefore aldosterone. So you'll have a decrease in salt and water reabsorption into the blood stream and therefore causing a decrease in peripheral vascular resistance or a decrease in blood volume or resulting in a decrease in blood pressure. And here also beta blockers cause a reduction in renin, which also further, as I mentioned earlier, also decreases a reduction in aldosterone and decreases angiotensin, resulting in the decrease in blood pressure, decrease in heart rate, but also most notably is it slows the conduction through the AV node. The SA node fires the natural pacemaker in the heart in the atria, fires at 60 to 100, sets the heart rate for the natural pacemaker for the heart, 60 to 100. The SA node fires on the AV node. The AV node's heart rate is normally somewhere between 40 and 60. SA node fires on the AV node to send down the depolarization from the SA node to the ventricles so the ventricles can start to contract. This is seen in the EKG, as we'll see in class, as the PR interval. The PR interval, SA node firing on the AV node, which is the distance in the ECG, is the P to the R wave. And whenever you slow a heart rate, you slow it with a beta blocker, you extend this period of time, so the PR interval is prolonged. Just make note of that, and we'll look at that more closely when we get together in class. So here listed are some of the uses for beta blockers. I'll let you explore those. Migraine is unusual. It's just it's a side effect that we found over time. So here are some of the side effects of beta blocker and there's the implications. Obviously, if a patient's bradycardic, you would hold it if their blood pressure, or if their heart rate is less than 60. You would also hold it if their blood pressure, systolic blood pressure, was less than either 90 or 100. Either or is usually ordered. You use caution with diabetics because it can mask the stress response associated with hypoglycemic recovery. Think about that's podcast number 2. Remember all the reactions that you get to stress. You don't have recovery of gluconeogenesis. You don't have that stress response anymore. The diaphoresis. The tachycardia, all those symptoms are gone. So patients with diabetes who undergo hypoglycemic attack, those symptoms are blunted. Patients with asthma, they may succumb to bronchoconstriction if they do not have a selective beta blocker that's just blocking beta 1s. You don't want them to have beta 2 blockade. Unfortunately, it also causes increases in LDL levels and it decreases HDL levels. And in men particularly, it can cause impotence and can cause a poor quality of life. And the number one reason for noncompliance with this medication is impotence in males, particularly diabetic males that are at double in diabetes can cause impotence. Beta blockers can cause incidence, so the incidence will increase in these patients.